Good morning to all and welcome back. I'm going to start my lecture series on glaucoma now. There'll be 4-5 lectures in which I'll be talking about primary open angle, secondary glaucomas, primary angle closure glaucoma, and their management. So let us begin with primary open angle glaucoma, which constitutes about half of the cases of glaucoma that you will come across. So what is glaucoma? It is a multifactorial optic neuropathy. Multifactorial optic neuropathy, mind you, the definition is important, and it is progressive in nature. So it's a multifactorial progressive optic neuropathy in which there is a characteristic atrophy of the optic nerve known as glaucomatous optic atrophy and loss of retinal ganglion cells and their axons. It is the retinal ganglion cells and their axons which make up the optic nerve, as you already know. Abnormally elevated IOP was previously a part of the definition, but studies have shown that it is a risk factor. IOP may not be elevated in all the time and in all the cases of glaucoma. Now coming on to primary open angle glaucoma per se. So it is characterized by an open, normal appearing anterior chamber. Open, that is why we are calling it open angle. Normal appearing anterior chamber. So there is no secondary cause of the glaucoma per se. So an open normal appearing anterior chamber angle, that is why it is primary and open angle. Now increased intraocular pressure, number 2. Number 3, typical optic nerve head or the optic disc damage or glaucomatous visual field damage. These have to be there for you to diagnose it as a case of glaucoma. The typical optic nerve head changes or glaucomatous visual field changes must be there. Lastly, without any apparent ocular or systemic abnormality that might account for the same. If an ocular or systemic abnormality is causing the glaucoma, it becomes a secondary glaucoma. So, no apparent cause, open angles, elevated IOP, and signs of the optic disc or the optic nerve head damage or visual field loss. That is the 4 characteristic features of primary open angle glaucoma. Now the pathogenesis. You know that the aqueous humor is one of the intraocular fluids produced by the non-pigmented ciliary epithelium over here in this region. It moves forward out through the pupil, bathes the anterior chamber and exits through the angle over here. This is a magnified view of the angle of the anterior chamber. This is what is in a normal eye, the aqueous production and circulation and its outflow. Now, what happens in a glaucomatous eye is that fluid comes out, reaches the angle, but cannot exit. The problem lies here, as a result of which it builds up in the anterior chamber. Now, it has nowhere to go, so it exerts a pressure posteriorly into the vitreous and onto the optic nerve head over here. Now, the optic nerve head is fragile. It is present in the opening of the sclera known as lamina cribrosa, as you already know. So when there is a pressure here, it tends to deform the optic nerve head. So as much as possible, it gets deformed into that sieve-like opening of the lamina cribrosa, and that is what you clinically see as enlargement of the optic cup. So this is what is happening in glaucoma, and this diagram largely depicts the mechanical theory of primary open angle glaucoma. That is, there is mechanical pressure at the optic nerve head. Recent studies have also suggested a vascular theory, which states that there is some compromise in the vascular supply of the optic nerve head, which leads to retinal ganglion cell death and loss. So reduced aqueous outflow, raised IOP, pressure changes at the optic nerve head, and ganglion cell axonal loss. So one factor that is the supports the vascular theory adds on to this and also contributes to ganglion cell axonal loss. That's the two theories, mechanical theory and vascular theory of pathogenesis of primary open angle glaucoma. Predisposing and risk factors. The intraocular pressure is the most important and the only modifiable risk factor. Now that we know the pathogenesis of glaucoma, we can modify one of its most important risk factors, that is the intraocular pressure. Older age, 40 years, more common in blacks than whites. Central corneal thickness. Studies have shown that the thickness of the central cornea in itself is inversely proportional to the occurrence of open angle glaucoma. That is, thinner CCT or thinner corneas are supposed to be a risk factor for glaucoma. Vertical CD ratio. Now this CD means this is the optic nerve head. This is the fundoscopic appearance of the optic nerve head. That pale part in the center is the optic cup. The entire thing is the optic nerve head or the optic disc, and this pink rim that you see is the neuroretinal rim. We will understand the ultrastructure of this appearance in the subsequent slides. So by ratio we mean the ratio between that pale cup and the entire optic disc. That ratio more than 0.7 is a risk factor. However, mind you, this ratio can also be physiological. Myopia, family history of glaucoma, a very high chance if a first degree relative has glaucoma already, and systemic associations like diabetes and hypertension, which support the vascular theory of open angle glaucoma. So at a microscopic level, let us understand the pathogenesis. So I told you that this is the aqueous, this is how it moves, and this is how it exits, and the problem lies somewhere over here in the aqueous outflow. So what problem is there? There is thickening and sclerosis of the trabecular meshwork, right, which is a part of the anterior chamber angle. There is narrowing of intertrabecular spaces, deposition of amorphous material in the trabecular meshwork, and collapse of the Schlemm's canal. Aqueous passes from the trabecular meshwork into the Schlemm's canal, into the collector channels, into the episcleral veins. That's the outflow facility. So problems in the trabecular meshwork and problems in the Schlemm's canal have been noted in animal studies. Coming on to epidemiology, 1 in 100 of general population above 40 years is affected. It contributes to actually more than 1/3 of all the cases of glaucoma. So you see, in Indian population, primary open angle glaucoma and primary angle closure glaucoma have an equal prevalence, 1:1. In the Chinese, angle closure is more common because of the anatomical structure. Same in the Mongoloid cases, whereas on the contrary, in European, African, and Hispanic races, the open angle is more common than angle closure, at least 5 times. So coming on to the clinical features of open angle glaucoma. Now you see, when you get a long question and you're supposed to describe the clinical features and you're supposed to write down the symptoms, you must know that this disease is insidious and asymptomatic. That is the first point you should mention in your answer sheets, because it is true. People present to us at a very advanced stage, at a very advanced disease of glaucoma, when they have either developed a partial loss of the visual field, or have become completely blind altogether. This would not have happened if the symptoms were very much prominent or problematic. So you must know that primary open angle glaucoma is an insidious and asymptomatic disease. That is the first point. There are no symptoms. There may be non-specific things happening, such as a mild headache, eye ache, a frequent change in the prescription, glasses prescription, and in advanced diseases, you're going to have delayed dark adaptation, problems in dim light, visual field defect, which are known as scotomas. We'll see what scotomas are, significant loss of vision, and eventually blindness. So the patient actually comes at stages 5 and 6, and that is why glaucoma is often referred to as the silent thief of sight. Coming on to the signs. So the signs are what you see as a clinician. Now, when you look at the anterior segment, there is nothing. It's a perfectly normal cornea. Anterior chamber angles are open, although you should evaluate the angle by gonioscopy, which I will be talking about briefly. So the problem where you see is in the optic disc, right? When you do a biomicroscopic examination. Now that is the best way to examine the optic disc, using a +90 or a +78D lens at the slit lamp. So the first thing, optic nerve head evaluation or optic disc evaluation. Now we know that this is the cup, this whole structure is the optic disc, and this pink rim is the neuroretinal rim. There is also a diagrammatic representation of the same, and there is a cut section. Why this appearance is the way it is, right? So I hope you have understood the anatomy of the normal optic nerve head or the optic disc, right? So there are two parts, the pale optic cup and the pink neuroretinal rim. Now the thickness of the neuroretinal rim, it is this rim that is the most important. It is this neuroretinal rim that is lost. What is this rim made up of? It is made up of ganglion cells and their axons. So it is the ganglion cells and their axons that are lost in this disease. So there is a thinning of this neuroretinal rim, which is the characteristic feature of glaucoma. That thinning happens in a particular pattern, which is the characteristic feature of glaucomatous optic disc cupping. Now, in normal individuals, the thickness of this rim follows the isn't rule, which simply means inferior rim is the thickest, followed by superior, followed by nasal, followed by temporal. The temporal rim is the thinnest. The normal optic cup is to optic disc ratio is 0.1 is to 0.4, but it is variable with the size of the disc. A large sized disc would also have a proportionately large sized cup, so it is our job not to confuse it with a glaucomatous optic nerve head. Asymmetry between the two eyes is less than 0.2 in normal individuals. So this cup disc ratio, the difference in the cup disc ratio between the two eyes should not be more than 0.2. Early glaucomatous changes in the optic nerve head include a vertically oval large cup, as you can see in this image, asymmetry of 0.2 between the two eyes, large cup that is 0.6 or more, but this could also be physiological, disc pallor. You see, this is the pallor of the cup. It is this pallor that increases in size and it looks like disc pallor. And RNFL wedge defects. These RNFL wedge defects are basically wedge-shaped areas of loss of retinal nerve fiber layer. Why is the area wedge-shaped? Because the RNFL is arranged in that manner, in an arcuate fashion. When you read the anatomy, you will realize that there is a certain arrangement of the retinal nerve fiber layers all over the retina and the way they come and gather at the optic nerve head. So that is why these wedge defects happen. I will show you. This is that wedge defect that you see. This part, now that I have highlighted it, it appears differently colored. It is more properly pronounced when you do a red-free picture of the optic disc. You see, this is a fundus picture of the optic disc, a red-free image. See this dark band over here, almost like a wedge. So that is the RNFL loss. All these are early glaucomatous changes that you can pick up at the slit lamp biomicroscopy if you have a very keen eye. Advanced glaucomatous changes. So this is the stage at which the patients usually present. There is marked cupping. Look at this. This is a diagrammatic representation. So you see the cup is here. We know there was this isn't rule wherein the inferior rim was supposed to be the thickest, but you see that the inferior rim, sort of inferotemporal rim, has been lost completely. So you just try to superimpose this diagram on the clinical picture that you see here. See, the rim is there all around, but it seems to have lost here, somewhere over here, focally lost. So this focal loss is known as notching of the neuroretinal rim. Sometimes you can see a generalized thinning, and that is known as a generalized thinning of the NRR, or focal loss is known as notching. Marked cupping, nasal shifting of retinal vessels. Now, that nasal shifting you see over here, see? Because of the enlargement of the cup, these vessels seem to have shifted onto the nasal side from the center. This is known as nasal shifting of the retinal vessels. And finally, lamellar dot sign. Lamellar dot sign means the pores in the lamina cribrosa become prominent. Now, I don't know if you can appreciate in this figure, there are these tiny dots. Now, this is a very advanced form of glaucomatous cupping, the third picture. So you see these dots, these dark dots, subtle dark dots, these are the enlarged pores of the lamina cribrosa because of excessive deformation. Now, what I'm going to show you in this diagram, you look at this particular major blood vessel, right? In the cup, optic cup, right? Now, it should have come from here and directly exited through the margin. But no, something happens to it here. So this, you see, if you trace the vessel, oh, that's the focal notching, I'm sorry. Please pay attention to this diagram. If you trace the vessel, here it goes, and then it disappears, and then it reappears at the margin. So this sudden disappearance of the vessel below the cup, because the cup has deepened so much that the vessel sort of disappears below it and then re-emerges at another place. This sign is known as the bayoneting sign, because the vessel takes a takes a sharp angle looking like a bayonet. That is the bayonetic sign. Okay. This figure is showing you nasalization of the blood vessels, right? They have sort of moved, getting displaced from the center to the nasal side. And finally, the last stage is glaucomatous optic atrophy, where all neural tissue is lost. This is a near end stage atrophy where most of the neuroretinal rim, you see, there is a pinkish rim that you can see over here, but the rest of the rim has been lost. So the optic nerve head appears white, and that is what we call disc pallor. The entire optic nerve head or the optic disc appears white and deeply excavated. Glaucomatous optic nerve versus optic nerve diseases. Now you have to rule out some other appearances of the optic nerve, pathological appearances of the optic nerve, which might mimic the glaucomatous optic atrophy, and these include congenital abnormalities, physiological cupping. Some people might just have larger sized optic discs, as a result of which they will have larger cups also. Optic disc drusen, compressive lesions of the optic nerve leading to a compressive optic neuropathy, ischemic optic neuropathy, toxic optic neuropathy, nutritional optic neuropathy, right? These are the differentials of glaucomatous optic neuropathy. Now, gonioscopy is a part of the clinical examination. What you see on gonioscopy is technically a sign. So I am discussing it under the clinical signs itself. So gonioscopy is scopy means viewing. Gonio means angle. So it is viewing the angle of the anterior chamber. So this is a schematic representation. Now the principle is that any ray of light, see, for you to visualize the angle, you need to see light coming from it. So any light that is actually traveling from the angle, you cannot see that light because it gets reflected here. This is the principle of total internal reflection, right? That we read about in physics. So this is the problem. Light coming from here gets internally reflected and we cannot visualize the angle. So there is a technique to eliminate this total internal reflection. How? You place a prism over it or a mirror over it, basically any contact lens, such that the refractive index between the cornea, that is, or rather the tear film and air interface, this interface is eliminated and it becomes one continuous structure, such that light, instead of undergoing total internal reflection, undergoes refraction and reaches the observer's eye. Okay. Now, if the observer's eye is placed here, you see, at this region, if the eye is placed here, it becomes direct gonioscopy. Why? Because you see the light rays coming from this angle are reaching your eye directly. This is direct gonioscopy. Indirect gonioscopy is when your eye or the observer's eye is placed here. Understood? Now, why is it indirect? Because the light from the angle is getting reflected first by a mirror. That yellow thing is the mirror, and then reaching the observer's eye. So this is indirect gonioscopy. So I've told you the principles of direct and indirect gonioscopy. So you know already now that it's done with the help of a specialized lens known as the gonio lens. And in indirect method, you see a mirror image. If the eye is over here, you see a mirror image. Examples of these lenses are the Goldman 3 mirror and Zeiss 4 mirror. Then there are direct lenses. I told you about the direct gonioscopy also. So these are specialized lenses with a dome-shaped configuration, right? This is what the direct gonio lenses look like. They do not use a mirror, that is why they are direct. And the light rays coming from the angle are viewed directly. So you do not need a slit lamp even, okay, to examine the angle. So direct gonioscopy is useful in case of children and examination under anesthesia, and it is used to do angle surgeries or glaucoma surgeries on the supine patient. Okay, so what you actually see on gonioscopy is this. This is an enlarged view of the angle, right? This is the cornea over here. Rather, this is the sclera and this is the cornea here. Okay, this is the transition zone. Then here, this part, this filter like thing, the sieve like thing is the trabecular meshwork. This portion over here, now this was the sclera, this sharp edge, that's the scleral spur. The scleral spur is the area where the ciliary muscles are attached. So these are your ciliary muscles. You see they're attached to the scleral spur here. This point, this triangular jutting portion over here is the scleral spur, right? This is the termination of the ciliary muscle attached to it. Then comes the ciliary body. So this is the base of the ciliary body or the ciliary body band. Then this is the iris. So this part is the root of the iris. So basically the structures that you see here from anterior to posterior are the peripheral termination of the cornea and the beginning of the sclera, which is known as the Schwalbe line. Then you see a broad band, that is the trabecular meshwork. Then you see the sharp line, white line of the scleral spur, right? Imagine if you were to be sitting inside the eye in the anterior chamber over here and looking at the angle, then you would be able to visualize. So scleral spur, a white line, and then the ciliary body band, this region, a brownish pigmented band, right? So these are the four major structures. Try to visualize it from inside the eye. Then you'll be able to remember the angle structures. If not, you can remember with the help of a mnemonic, that is STSC. Okay. Schwalbe line from anterior to posterior. The Schwalbe line, this part is the Schwalbe line. It is the peripheral termination of the descemet membrane. It may or may not be pigmented. S, then T. T is the trabecular meshwork. Again, it may or may not be pigmented. It's a broad line extending from the Schwalbe line to the scleral spur, about 600 microns in thickness. It is the posterior trabecular meshwork which is pigmented and is the functional part. Scleral spur, the most anterior portion of the sclera, this sharp jutting out portion of the sclera. It's a narrow white line just behind the trabecular meshwork. And finally, the ciliary body band just behind the scleral spur in the form of a grayish or brownish band. So those are the structures you see in the angle, in a normal open angle, anterior to posterior. Now, those were the signs, those were the examination findings. Now we come on to the investigations. So tonometry means the measurement of intraocular pressure. The gold standard instrument for tonometry is the Goldman applanation tonometer. This is what it looks like. This device is fixed onto the slit lamp, and this is what the procedure looks like. What is the principle? Often asked in exam, what is the principle of Goldman applanation tonometry? This is known as the Imbert-Fick principle. Now, imagine the cornea to be a part of a perfect thin-walled sphere. Then, if you apply pressure on that sphere from outside, pressure of a particular intensity and of a fixed area, then the pressure inside that thin walled sphere would be equal to the force that you apply and upon the fixed area that you apply the force on. So the area is fixed, the force that you apply is variable. So the pressure inside is directly proportional, the area being fixed, the pressure inside the sphere is directly proportional to the force you are applying from outside. Remember, the area being fixed. Then that pressure corresponds to the intraocular pressure. This is the Imbert-Fick principle. P is equal to F upon A. Intraocular pressure more than 21 mmHg. The normal pressure you must know is 10 to 20 mmHg. More than 21 on more than one occasion. A one-time measurement is not diagnostic. Asymmetry of IOP more than 5 mmHg between the two eyes. Diurnal variation means uh, a day measurement versus an evening measurement. If the variation is constantly more than 8 mmHg, it is suspicious. And then there are certain factors which affect IOP. Supine position increases it. Time of the day, IOPs are found to be higher in early morning or late evening. Exercise, water drinking of that forms the basis of the provocative tests. One of the provocative tests for glaucoma in which the pressure rises when you drink a large amount of water. So water drinking test and forceful eyelid closure also tends to increase the IOP. So just some methods. We know that now that the Goldman applanation tonometry is the gold standard. There are some other methods. Pneumotonometry, in which instead of a probe on the eye, pneumo or air is used. Then there is a portable form of applanation tonometer known as the Perkin tonometer. This one is the Perkins tonometer. It's basically a portable modification of applanation tonometry. Then electronic modification, which is in the form of a pen. This is a tono pen. Then there is something known as rebound tonometry. This is rebound tonometry, in which there is a very thin ball-like structure that bounces on the cornea and bounces back. And then you measure the corneal the corneal hysteresis, in fact. So that is rebound tonometry. And indentation tonometry, which requires the contact of the tonometer on the cornea. This is Schiot's tonometry. It is mostly obsolete these days. The next investigation is perimetry. So in glaucoma, when the retinal nerve fibers from all over the retina coming onto the optic nerve, when these fibers or the RNFL layer is affected, what does that do? It affects the patient's field of vision. The retina, the entire peripheral retina, corresponds to a patient's visual field. When the nerve fibers in the retina are affected, the visual field is affected. So in a normal person, a visual field looks somewhat like this. It's in the form of a hill. Now the circles that you see here, imagine those circles to be a graph. Okay. So if you were to plot the visual field sensitivities at various retinal points on this graph, it would actually look like a three-dimensional structure like this, because the normal visual field nasally is different from that inferiorly, from temporally and superiorly, right? Temporally, we have the maximum visual field, okay? Whereas nasally, it is limited by the nasal bone or the nose, and superiorly, it is limited by the brow. Inferiorly, it is somewhat in between. So this is what, when you plot, the bluish part is the actual visual field of a normal person, right? With the maximum field being temporally, because there is no bony obstacle there. So measurement of the visual field is known as perimetry. Nowadays, what we use is standard automated perimetry. Okay. So talking about the field of vision, the central point, this point is actually your fovea. Always remember the fixation point or the central point when talking about the visual field is the fovea. There is a spot, blind spot, which is temporal to the fovea, always on the temporal side. That is the physiological blind spot or the physiological scotoma, and it corresponds to your optic disc. You know that the optic disc is a blind spot because there are no rods and cones over there, right? So this is the blind spot, just temporal, 10 to 20 degrees, or rather 15 to 20 degrees temporal to fixation. Remember. So this one is a physiological scotoma. Now coming back to our scotomas, what is a scotoma? A scotoma is an area of reduced or total loss of vision surrounded by a seeing area. So this one is your physiological scotoma or physiological blind spot. Now, this blue thing is the center, is your field of vision on it when you see it two-dimensionally on paper. And this is when you see it, when you imagine it three-dimensionally. So the maximum sensitivity is here at the fovea where the maximum cones are present, and the minimum sensitivity is here, just temporal to it, 15 to 20 degrees temporal to it, that corresponds to your optic disc. Okay? And gradually, as you move from the fovea to the retinal periphery, the sensitivity decreases. That is why these stepping shape is there, right? So three-dimensional representation, two-dimensional representation of the visual field. Central field, portion of the visual field within 30 degrees of fixation is known as the central field when it comes to perimetry. And there is a special area known as Jerum's area that is within 25 degrees of fixation. So you see this area. I think I can just, yep. So 25 degrees of fixation. This area that you see, this thing between your 20 to 30 degrees, this is actually your Jerum's area. This is the area where you will find most of your glaucomatous field defects. So let us just look at the normal field and some fields now. So this is the normal visual field, okay? Again, I told you the blind spot or the physiological scotoma is always on the temporal side. So this is how you identify the eye. This is the temporal side. So this is a visual field of the right eye. The blind spot is always temporal and slightly below the horizontal. So what is static perimetry? Definition: a method of assessing field, usually automated, in which the location of a stimulus remains fixed with intensity increased until it is seen by the subject, which is known as the threshold, or decreased until it is no longer detected. So static perimetry. Static means the stimulus remains static. Now what actually happens is that the patient sits on a screen, okay? And this patient is shown certain stimuli in the form of white dots. These are the white dots. And when the patient sees these white dots, he or she presses a button. In this way, several points are shown to the patient, which correspond to all the retinal points, covering the entire visual field. And when those points are plotted on a graph, this is what you get. So this is the normal visual field. Okay. Now, this is what is important for you: glaucomatous field effects. So again, the field of the left eye, okay? This is your blind spot. Now what do you see here? This is a paracentral scotoma. Why para? Because it is near central, near the center. So paracentral scotoma. That is an early finding. Arcuate scotoma. What's an arcuate scotoma? A scotoma that begins at the blind spot, arches over in the Jerum's area, and never crosses the horizontal raphe. That's an arcuate scotoma. So this one's a superior arcuate scotoma. Okay. These become progressively wider as they curve over the central fixation, and they also become denser. So this one's an inferior arcuate. Both are varieties of arcuate scotoma. Sometimes these arcuate scotoma can meet and result in the form of a ring scotoma or a double arcuate scotoma, wherein only a central island of functional vision remains. And this is a Rowen's nasal step. So in this case, again, a right eye visual field. This is the temporal side, the physiological blind spot. You see there is a scotoma here, like a step-shaped thing, which is not going below the midline. And it is confined to this area. Now this again happens because the nasal fibers, the particular nasal fibers corresponding to this visual field are affected. Let us just briefly understand how these defects result. So you see again optic disc corresponding to the blind spot. Okay, so this is the right side. Now you see this is the temporal retina, this is the nasal retina. Fibers from the temporal retina are coming like this. Okay, they are arching over the fovea. This is the fovea corresponding to your fixation point, this one. So fibers from the temporal retina are arching over like this and reaching the optic disc at the superior and the inferior poles. These are known as the arcuate fibers. Okay. Fibers from the fovea are traveling to the disc, the nasal margin of the disc directly, sorry, the temporal margin of the disc directly, and that constitutes the papillomacular bundle, a very, very important structure. So papillomacular bundle is nothing but the bundle of the retinal nerve fiber layers or the axons of the retinal ganglion cells traveling from the fovea onto the temporal margin of the optic disc. And fibers from the nasal half of the retina travel directly to the optic disc. So this is how the fibers are arranged. So basically a Rowan nasal step happens because of this phenomena. You see the fibers that are arching over either superiorly or inferiorly, they end at varying distances from the fixation point, and they do not cross the raphe. So they form a step-like structure, right? So this part is what leads to the Rowan nasal step. I hope you understand now. A shelf created due to difference in sensitivity above and below the horizontal midline caused by asymmetry in nerve fiber loss at the two poles of the optic disc. You know about paracentral scotomas, arcuate scotomas. Again, arcuate scotomas affect these fibers, right? And double arcuate scotoma is when the whole thing is affected. So that is just some of the important glaucomatous field defects that you should be aware of. Now, pachymetry or CCT, I told you, is important because it is a risk factor for development of open angle glaucoma. CCT corresponds to central corneal thickness. The normal central corneal thickness is about 500 to 50 microns, you can say. Now, why is it important? Because it influences applanation tonometry readings. A very thin cornea will give a falsely low reading of IOP. When you're doing applanation, I told you how applanation is done. So a very thin cornea will give a falsely low IOP. A thick cornea will give a falsely high IOP, right? So it is important that the thickness of the cornea is in the normal range, right? So this is a thickness map obtained from, you can obtain it from an orb scan or a pentacam. So you see the yellow area, basically the yellow and the red are the dangers. The yellow is okay still. The red is the danger sign, thinner to thick. This is how it proceeds. The cooler colors indicate thicker cornea and the warmer color indicates thin cornea. So 531 is pretty okay. Patients with NTG. Now NTG we'll discuss in a little while is normal tension glaucoma. These patients tend to have thin CCT measurements, and it's an important factor in determining the risk of conversion of glaucoma in individuals with raised IOP. This is a recent advance, okay, imaging in glaucoma. So just like you observe the optic nerve head with at the slit lamp using a 98 or a 78 DA, that is known as slit lamp biomicroscopy, the machine can also observe the optic nerve head in the same way. So there are two most commonly or most commonly used technologies. One is optical coherence tomography or OCT. Remember we talked about OCT macula when we talked about diabetic retinopathy, right? So just like you can image the macula, you can also image the area of the optic nerve and the area around it. Okay. So what the machine does is it makes a map of the retinal nerve fiber layer. Now the retinal nerve fiber layer is thickest in this region, and that is why it obtains a cross section of the nerve fiber layer at this region only, and this is known as peripapillary RNFL, right? A circular scan of the retina around the optic nerve head. It measures the thickness of this region and it gives us in the form of a map, which is like this: the red areas showing thinning, the green areas showing normal thickness. Another technology is scanning laser polarimetry. Now, as a matter of fact, the retinal nerve fiber layer is a birefringent structure, means that it can split polarized light when passed through. So this nature is used to affect the nerve fiber layer thickness. The amount of polarization of light is directly related to the thickness of the retinal nerve fiber layer, and that is the principle of scanning laser polarimetry. So just some recent advances in imaging since we were talking about investigations. So that is all about the clinical features and investigations in primary open angle glaucoma. We talked about the appearance of the optic nerve head, the appearance of the angle structures, normal looking angle, the normal visual field and abnormal visual fields. Then imaging with the help of RNFL imaging via OCT and scanning laser polarimetry. So that is about the investigations and evaluation of open angle glaucoma. Now just a few slides on some distant cousins of primary open angle glaucoma, which are similar to open angle glaucoma but not really open angle glaucoma. So we know that primary open glaucoma is raised IOP associated with definite glaucomatous disc cupping and visual field changes. So you're familiar with Venn diagrams from school. So when all the three criteria are satisfied, it is an established glaucoma. Okay. The pressure is raised, there are disc changes, there are field changes. All the three should be there to establish glaucoma. What happens if all the three criteria are not there? What if only the IOP is raised? but there are no disc changes, there are no field changes. This is known as ocular hypertension or glaucoma suspect. What happens if there are typical disc changes or field changes, but the IOP is normal? What is that? That's a normal tension glaucoma. Typical glaucomatous disc cupping or field changes without raised IOP. So this is the entire spectrum of glaucoma and its cousins, that is ocular hypertension and normal tension glaucoma or NTG. Let's just know about them a little bit in details. So ocular hypertension is defined as a condition in which the IOP is elevated above 21 in the absence of optic nerve, RNFL or visual field abnormalities. There are certain risk factors uh, for progression of ocular hypertension to full-fledged open angle glaucoma, that is increased age, increased CD ratio, a thin cornea, see CCT less than 550, and persistently elevated IOP above 30 mmHg. Those with any of these high risk factors should be treated just like POAG. The treatment reduces its progression to full-fledged POAG or primary open angle glaucoma. Normal tension glaucoma is when there are typical disc changes and or field changes, but IOP is constantly below 21 mmHg. Now, it has been speculated that the causes of this, see, if the IOP is low, the mechanical theory does not hold, right? So, this is where the vascular theory comes in to explain the pathogenesis of normal tension glaucoma. So, there can be chronic low vascular perfusion, which makes the optic nerve head susceptible to even normal IOP, right? Now, this chronic low vascular perfusion are known to be associated with these conditions, vasospastic conditions like migraine and Raynaud, ischemic vascular disease, autoimmune disease, obstructive sleep apnea, systemic hypotension, and coagulopathies. So, normal tension glaucoma may be something that requires a systemic evaluation. Now, this, what you see here, this is a disc hemorrhage known as Drans hemorrhages. These are RNFL layer, superficial RNFL hemorrhages happening at the disc margin. Very, very pathognomic of normal tension glaucoma. Please remember that. So what systemic assessment should you do in a patient of normal tension glaucoma? Blood pressure measurements to exclude nocturnal hypotension. Blood tests to exclude non-glaucomatous optic neuropathy. Indications for neuroimaging include disproportionate if there is excessive loss of visual acuity, excessive disproportionate loss of color vision, disproportionate loss of visual field, excessive pallor of the NRR. See, normally the disc changes shouldn't be there, right? In a normal, no, excessive pallor of the neuroretinal, okay, pallor of the neuroretinal rim, I'm sorry, not the pallor of the disc. So if this, characteristically in glaucoma, it is the rim, the whatever rim that is there, it is healthy. Okay, it is only the enlargement of the cup that is making you give the appearance of a pale disc, but the whatever the rim that is there, it is pink. If this rim is losing color, it is indicative of normal tension glaucoma or some secondary cause of optic neuropathy. And if there is rapid progression despite normal pressure. So these are the conditions in NTG where you need to do a systemic assessment in order to rule out more life-threatening underlying conditions. So you might be interested in doing a carotid Dopplex, okay, which measures the circulation of the internal carotid and the ophthalmic artery, which actually perfuses the optic nerve head. So that's about it. That covers your open angle glaucoma, normal tension glaucoma, and ocular hypertension. I have tried to be as concise as possible. And the next lecture would be on angle closure glaucoma. Thank you very much. Please continue watching my opthal teacher.